Bronchial angiography. Bronchial artery anatomy is extremely valuable. Most common patterns or classification schemes vary from an author to an author depending on the source, whether it's autopsy, cadaveric dissection, or angiography. The bronchial arteries to the left and right arises from thoracic aorta, usually from T4 to T9, but about 90% arises from T5 to T6 levels. The bronchial anatomy is quite variable. Most common pattern is three arteries, one right and two left in 40% of people. Can be single artery on the right, single artery on the left in 30% of people, and two arteries bilaterally in 25% of people. There are a number of clinical indications for bronchial angiography, but the vast majority of the complications in the adult practice is hemoptysis. Other indications can include obstruction of the pulmonary artery, congenital cardiomyopathy with interruption of the pulmonary artery, evaluation of bronchial arterial system, post-lung transplantation, and pulmonary sequestrations. During the bronchial angiography, the actual hemorrhage will not be seen or rarely be seen because usually it is not sufficient enough to the degree that it presents as a contrast extravasation angiographically. Usually we see areas of hemoptysis as areas of abnormal appearing bronchial arteries. These abnormal appearing bronchial arteries usually supplies the area of hemoptysis. For example, you can see there is here a bronchial artery catheterization it shows a common trunk, both the left and the right appearing large, but the right is larger and tortuous and abnormal looking, indicating that these are the areas of the hemoptysis or the causative agent of the hemoptysis. Regarding peripheral arterial disease, multiple disease processes can affect the peripheral arteries. Regarding obstructive arterial disease, prior to the radiographic imaging, it was usually diagnosed based on the physical examination of the upper and lower limbs using laboratory tests, using the ankle brachial index. The Doppler waveforms and segmental limb pressures can be also used as a non-invasive means of evaluating peripheral blood flow. The main disease that affects the peripheral arteries is, of course, atherosclerosis. Usually, patients can present with either acute or chronic symptoms, usually acute or chronic. The angiographic findings are that of multifocal diffuse luminal irregularities with areas of occlusion and variable calcification. The most common location of atherosclerotic disease is the lower limb. In the lower limb are the superficial femoral artery, the adductor canal, common iliac artery, popliteal artery, tibioperoneal trunk, and the origins of the tibial arteries. For example, you can see here in the superficial femoral artery, there are multiple luminal irregularities and narrowings with one predominant stenosis here, which was treated by angioplasty, and you can see restoration of the lumen with satisfactory blood flow after angioplasty. Regarding the thrombosis and embolism, the acute ischemia of the lower extremity in the absence of occlusion of a vascular bypass is the most commonly results from embolism, and the most common site of this embolism is cardiac. We'll talk briefly about few pathologies that affects the peripheral arterial system. First, we'll start with the giant cell arteritis, which typically involves medium to large sized blood vessels supplying the head in the temporal arteries, neck in the carotid arteries, and arms in the brachial arteries. Berger disease is characterized by pathologic findings consist of acute inflammation and thrombosis or clotting of the arteries and veins, primarily affecting the hand and feet, usually in young males who are heavy smokers, and angiographically present as very characteristic corkscrew appearance. Trauma, whether blunt or penetrating, can occur to any artery, although more common for some arteries than others. Fibromuscular disease has been described in the subclavian, axillary, and brachial arteries of the upper extremity and the iliac, femoral, and popliteal arteries of the lower extremity. Vascular entrapment of compression or compression, as in, for example, thoracic outlet syndrome, corresponds to a spectrum of disorders of the upper extremity and remains somewhat controversial subject. Adventitial cysts and tumors. The only role for angiography in the extremity tumor is the embolotherapy prior to resection of a highly vascular tumor, for example, in renal cell carcinoma metastasis. A pathologic entity called arteriomegaly, also other names sometimes called diffuse vascular ectasia, arteria magna, ectatic atherosclerosis. It is an unusual manifestation of aneurysmal disease with diffuse generalized dilatation of the aortoiliac and femoral vessels. The other pathologic entity is arteriovenous malformations. It has various classification systems ranging from hemangiomatous to annidus IVMs or single hole fistula can be a combination of these. About 60% of all peripheral vascular malformations are found in the lower extremity, with another 25% in the upper extremity. Just brief talk about the uterine artery embolization. It's an accepted treatment for symptomatic leiomyomas, offering an alternative to other invasive techniques like MR-focused ultrasound, myomectomy, or hysterectomy. Patients may present with bleeding, bulk-related symptoms, or pain. The treatment requires clinical evaluation and imaging with MRI to determine the type of the fibroid and to determine whether it correlates to the clinical symptoms or not. For example, in this case, you can see there are multiple leiomyomas here, and you can see there's abnormal thickening of the junctional zone here, indicating adenomyomas. Adenomyoma, it's due to adenomyosis, which is migration of the endometrium into the underlying myometrium. Another case, you can see there is marked thickening of the junctional zone here. You can compare it with the normal junctional zone here. This indicates adenomyoma. So embolization is performed from unilateral femoral access, selection of both right and left uterine arteries. Care should be taken not to reflux the embolic agents into the branches of the internal iliac artery. Branches of the uterine artery should be evaluated like the cervical or ovarian branches. To prevent non-targeted embolization, usually we use 500 to 700 microns PVA particles. This allows sparing of the normal myometrium. The catheter should be placed in the horizontal portion of the uterine artery for the injection of the particles. For example, in this angiography of the left uterine artery, you can see there is an abnormal vascularity here representing the vascular leiomyomas. After injection of particles, you can see the complete disappearance of this abnormal vascularity, indicating successful treatment. Follow-up MRI must be used to assess the vascularity of the fibrosis and to determine the size change, which may predict the outcome as well as the risk of recurrent symptoms. For usually 20 to 40% reduction in the size of the fibroid occur at 3 months. Lack of enhancement of the fibroid is related to successful outcome, and there is low incidence of recurrent symptoms. In this case, after embolization, this is an MRI T1 post contrast showing complete lack of enhancement in these fibroids, indicating successful treatment. The risk of delayed infection seems to be related to the presence of submucosal fibroids. Large pedunculated fibroids within the uterus carry a higher risk of infection. Other possible complications include early onset menopause, uterine necrosis, passage of fibroid material, and non-targeted embolization. The impact of embolization on the fertility has not yet been established. This will be all for this chapter. Thank you very much. Thank you, Dr. Tara Kawa, who presented this chapter. Hope to see you next week with the other chapter on the fundamentals of diagnostic radiology. Goodbye.